welcome to the last CLSP seminar of this semester. Of course, not the last series, there will be more next semester and so on. But this is the last one before we close up and go home and celebrate the holidays. It's a pleasure to end on a good note on our people here. I'm happy to present Dr. Dana Boatman. I was actually looking through her CV on the web, and I was quite pleasantly surprised to see she has a BA in French and philosophy from Brentwood age 1. Then she went on to one of our rivals in speech and language, University of Pennsylvania, where she has a MA and a PhD in linguistics and applied linguistics. Then she spent a fellowship at Johns Hopkins in the neurobiology department of the School of Medicine. And of course, right now her research area is mainly the human central auditory system, and she does research in the cortical modeling of speech perception using electrocortical mappings. And she has an appointment, actually 2 appointments, one as associate professor of neurology, and also a secondary appointment as associate professor in the department of otolaryngology, head and neck surgery. And my memory of her actually goes back to my very first semester here at Hopkins. I remember, I think this was in '96. And she gave a seminar. At that time, I knew very little about speech and language. And she had this, these patients whose heads were cut up, and there was an electrode or a grid placed on their brains, and they were performing some linguistic functions, and they were trying to figure out where the auditory functions are on the brain. And I said, I'm never going to go into surgery at Hopkins. But anyway, it turns out that it's great research, and she's going to talk to us today about cortical modeling.
Great, thank you. Thanks so much for inviting me, and I'm glad to have the opportunity to give you an update on our research progress. I'm going to be talking about the issue of auditory processing largely from a clinical perspective, which I know is a little bit different than what you might be used to hearing. As an audiologist, which is what I am, and we'll see if we can get the slides to work. No. Nope.
This room is full of computing experts, so why not somebody else today?
We know they were working before. It seemed to be. We'll go back to the. Okay. So I see, here we go. So I see patients in clinic, most of whom are children, and they're referred for testing because they're having trouble in one or more of these following areas. And these areas form the basis for the diagnosis of an auditory processing disorder, which is what we do. And the areas include the ability to discriminate speech sounds, or what are otherwise known as phonemes. It also includes the ability to fill in for missing information from the acoustic signal. So for example, the signal that you get on the telephone or in a room that has poor acoustics, you may be missing some of the high frequency information. Our ability to fill in that information is somehow impaired in a number of the children that we see. Other areas that we look at are auditory pattern recognition, or the ability to sequence auditory information, auditory temporal processing, also the ability to process a signal in the presence of competing background noise, which is a really big issue that I'll come back to, and then sound lateralization and localization. So those are some of the areas that we look at clinically. And while auditory processing disorders can affect the ability to process all different types of auditory information, in clinic we focus primarily on the ability to process speech information for obvious reasons of the importance of language development and also academic progress for these children. Auditory processing disorders come in 2 types. They can be acquired. So for example, patients who have difficulty processing or understanding speech after a stroke. That would be an example of an acquired auditory processing disorder. Or they can be developmental, which is typically what we see in clinic. And in terms of developmental auditory processing disorders, we know that these affect at least, and this is a conservative estimate, 20% of children who've been diagnosed with learning disabilities. And then about 4 to 7% of all school-aged children have difficulty processing auditory information. And I say children here, but typically you don't outgrow an auditory processing disorder. So there are plenty of adults walking around with them. Probably in here at least one or two of you will recognize some of the features that I'll be describing. We don't usually see adults in clinic as much because for the most part they figured out ways of compensating for the difficulties where they're no longer in an environment where it shows. We know that there are a number of risk factors for developing an auditory processing disorder. One of the largest is a history of chronic ear infections. And by chronic, I mean a child who has had, and this goes back to our discussion of ear infections earlier, who has had 6 or more ear infections before the age of 2 years. They are definitely going to be at risk for developing an auditory processing disorder. Other risk factors include conductive hearing loss, which goes along with ear infections, and also a family history. There definitely seems to be sort of a genetic component to this, which we don't quite have a good handle on yet. But in case history, it comes up repeatedly that a family member also has some similar difficulties. In terms of differential diagnosis, you want to rule out a hearing loss, which can very easily mask as an auditory processing disorder, especially a high-frequency hearing loss where you can't hear the consonant acoustic cues in the high-frequency range. ADHD refers to attention disorders, which also can easily mask as an auditory processing disorder. And actually, there's some overlap between the two, which is somewhat difficult to tease apart clinically. And then there are a number of neurodevelopmental disorders, including autism, that have the feature of an auditory processing disorder. But auditory processing disorders can stand on their own independently as well. Currently, we have no effective medical treatment for dealing with auditory processing disorders. For the most part, we have to rely on therapies or compensatory strategies. Yes?
The term auditory processing disorder is referring only to cortical disorders?
No. It can refer to, and I'll get to that in just a second, it can refer actually to a disorder anywhere along the line in the central auditory system. I'll actually be focusing on the cortex because that's where we think the primary area of dysfunction is. But technically, you could have a brainstem disorder that would result in an auditory processing disorder. It's all upstream from that anyway. So,
right.
Yeah, I'll come back to that in a second. What we do know is it's in most cases, it's not a peripheral hearing loss. So no medical intervention, effective medical intervention. And then lastly, we recognize 2 main clinical subtypes of auditory processing disorders. And these account for about 90% of the cases. And for the most part, they're mutually exclusive, although in a very severe case, you can get features of both. One is called speech decoding disorder, and the other is a speech and noise disorder. The speech encoding subtype refers to trouble processing or manipulating those individual speech sounds. This is also called phoneme awareness or phoneme processing. And we know that that's a skill that's implicated in normal language development of areas like reading and spelling, and in really severe cases, articulation as well. So these are children who, if you give them an unfamiliar word to read out loud, they'll have a lot of trouble sounding it out. They either will not make an attempt, or if they do, it's going to be incorrect. These are also children who have trouble with sound discrimination and have a lot of difficulty when the signal itself is in any way degraded. So not just in background noise, but in a room with poor acoustics. And that's what most classroom environments are. These are the kids who have a history of the ear infections. It mostly results in a speech decoding difficulty. There may or may not be a family history of speech language or some reading problems as well. And then in terms of differential diagnosis, you want to rule out a hearing loss, especially a high-frequency hearing loss, which can look very much like this, and also dyslexia. About 20% of children who have dyslexia have trouble with auditory processing, which makes sense. And then the other differential diagnosis is receptive language disorder, which is more on the aphasia end. So that's one of the main subtypes. The second subtype is called a speech and noise subtype. And actually, clinically, it's referred to as tolerance fading memory subtype, which I find completely non-transparent. So I call it speech and noise subtype. And this refers to the ability of a normal listener to focus on a conversation in the presence of background noise. And this is very familiar to the problem for those of you who are involved in engineering or in speech recognition projects. And our ability to do that is disrupted in these children. So they can't even figure out who's talking. And this ability requires that 3 things we know. One, the central system has to be able to suppress the background noise to some extent. There is an increased attention demand, so you're increasing your attention or shifting attention. And then also you need to be able to compensate for the loss of information that's masked in the signal by the presence of the background noise. And this is one of the most common types of auditory processing difficulty that we see. I'm sorry. For some reason, and we don't as yet understand fully why, children who have these speech and noise difficulties also almost always have two additional features. One is called hyperacusis. Hyperacusis is it's an over response to or an increased sensitivity to, in particular, loud sounds. So these are the kids who will put their hands over their ears when the vacuum cleaner is running or in the presence of a siren. They really find loud sounds intolerable. The other feature that goes along with it is poor auditory working memory. And the circuitry that's involved in why these three features so frequently go together, we don't yet fully understand. In this case, the differential diagnosis, once again, is hearing loss. But these are the kids who look like they have an attention problem. And in fact, by the time we see them in clinic, almost all of them have already been given some form of medication, methylphenidate, have not had a good response to the Ritalin or the Adderall or whatever, and they come in to the clinic. And the reason is because if it's an auditory processing disorder and they're having difficulty in background noise, that will not respond to the medication that is used for attention difficulties. So, let me back up here for a second. Oops, sorry, bear with me here. So, auditory processing refers to what we do with what we hear. And I actually have some graphics that are missing here for some reason. It's okay, we can go on. So one is, part of the differential diagnosis involves ruling out a hearing loss, and that's for both of the subtypes that I mentioned. So the peripheral auditory system in these children is functioning normally. The outer ear, the middle ear, the inner ear, and the auditory nerve. And we can test that by routine hearing tests. So, and in most of these children, there's no difficulty with their ability to detect or to hear sound. And that makes sense because the problem has more to do with what they're doing with the sound once it's been heard or detected. And so now we're talking about the central auditory system. And I know a lot of you are very familiar with this system. It's a very complex series of both parallel and crossing fibers, beginning down with the cochlear nuclei and extending all the way up to the cortex. And there are two main components of the system that have been implicated previously in central auditory processing disorders. One happens to be the brain stem. So we know peripheral hearing is normal, and then the attention focused on the brain stem. Maybe there's something going on there. And that makes sense, especially for children who have the speech and noise difficulties and the hyperacusis, because the ability to suppress the background sound and the reflexive response of the system in the presence of a very loud sound are both associated with the brain stem. This is also an area of the auditory system that's been implicated in children with autism who often have that hyperacusis and also trouble in background noise. So it makes sense. It was a logical idea that there may be a dysfunction at the level of the brain stem in these children. And while it's intuitively appealing, there is not a lot of clinical evidence for it, and that includes our own studies as well. So using the tests that we have clinically, which include acoustic reflexes, which measure an automatic response of the system to the presence of a loud sound, auditory brainstem responses, which measure the response of the system to sound from the lower part of the brainstem up through the upper part of the brainstem, middle auditory evoked responses, which look a little bit higher level, more at subcortical structures. All of those tests with all of the results of those tests are typically normal in these children. Now that's not to say that there may be some dysfunction at the level of the brainstem, but on our clinical testing, for the most part, these are normal in these children. And so for that reason, the attention shifted up, and this goes back to your question, now to the level of the cortex. And so we're looking on the top part here at a lateral view of the left hemisphere, and the area that I'm talking about is at the level of the cortex is the get this going, temporal lobe. Can you see that? It's actually not so clear, is it? Right, and this is the temporal lobe right here, which is associated with auditory processing.
Are you showing something?
Yes,
Yeah.
very faintly. Maybe we should be testing visual processing instead of auditory. Okay, so we may skip the pointer. But anyway, so we're talking about the temporal lobe, which is associated with auditory processing. One of the main areas is inside of the sylvian fissure on this plane here, and this is primary, thank you, primary auditory cortex. Oh, this is wild. This is a pen and a pointer at the same pen. There we go. So inside this sylvian fissure here is one of the primary.
Now you're not showing it.
Right here.
Oh, now.
Now I am worried. Okay, right here, inside the sylvian fissure. So let me actually.
I mean, before when.
So we're talking about inside the sylvian. Do you see where the sylvian fissure is?
Okay.
Because they want to see it.
I see it.
You know where it is.
It's not showing up.
I don't know. So, okay.
Why did you want for it, James?
Okay, so inside the sylvian fissure, in this area right here, we have our primary auditory cortex, which also includes Heschel's gyrus and some other areas as well. And then what we've been interested in is coming out more on the lateral surface of the temporal lobe, an area called auditory association cortex. And this is an area that's implicated in stroke patients who have a lot of problems processing speech sounds. So it made sense to think that this might be an area that could be dysfunctional in these children with auditory processing disorders. So we know they have normal hearing and normal brainstem function. They have their neurological exams. The neurological exams are normal. You do MRIs or EEGs in these children, and they're also typically normal. We don't see evidence of any kind of structural abnormalities in this area. And so we've now kind of worked our way up through the auditory system, and so a lot of people are now, a very widespread assumption is that auditory processing disorders are neurologically silent. And this is a pretty prevalent view in the field right now. It's, however, not our view. And based on our own research and also that of others, we are starting to think that there may be neurological disorders or a neurological basis for these auditory processing disorders. They're just more subtle. They're not overt lesions. There may be a disorder in how auditory functions are processed both within a hemisphere and between the two hemispheres in the brain. And I'm going to be talking about preliminary results from 3 clinical studies that we recently initiated that provide some support for both of these hypotheses.
If you were wrong and it weren't neurological, what would it be?
Well, I'm going to beg the question a little bit because the answer that you would get if you said that to people who are involved in the rehabilitation of auditory processing disorders is, we don't care. I mean, there's not an overt lesion there. We don't care. We're interested in the educational implications. As long as there's not an overt lesion or something that can be fixed medically, let's just get on with that. And you know, let's figure out some remediations for it. And I think that's kind of missing the point because if there is in fact a neurological basis for it, which I'm hoping to convince you that there is, then you can take it from there to develop some interventions for it that may target it a little bit better.
By neurologically silent, you didn't necessarily mean that there was no abnormality, neurological abnormality, just that the way you would only go about assessing impactness of the system is not going to be sensitive.
Yes and yes. So there are people who would tell you that there are probably no neurological abnormalities. This is just a variant of normal.
Yeah.
And then there are others that would just say that the tests that we have now just simply aren't sensitive enough to pick this up. So, any other questions? Yeah. I haven't even gotten to the grids yet.
I'm just thinking how ear infections in early childhood will end up affecting things way up in the auditory cortex. This has to be somehow detached with some developmental theory. Otherwise, do ear infections really, they don't go all the way up into the brain?
Well, what happens with the ear infections is that you often get a buildup of fluid in the middle ear because the eustachian tube is closed. And with the buildup of fluid in the middle ear, the sound isn't transmitting through the middle ear in the way that it should be. And sound transmits through the middle ear in the form of vibration. And the bones that vibrate optimally in air, if there's fluid in there, they're not going to. So as a result, you get a dampening of the signal as it comes in. If it's lowered and less, the integrity is degraded to start with down here, but that's going to affect what happens at the cortex as well.
Okay, so it's not the infection, but the development of hearing caused by the infection which causes the...
It's the effects of the infection. Is that?
It's not a physiological infection.
No, that's correct.
So the
Right.
developmental
Right.
process for a 0 to 2-year-old child,
Right.
that is being disrupted, and that
Correct.
supports the theory that it must be in the cortex.
Yes, exactly.
So chances are numerous ear infections in a 18-year-old wouldn't cause any problems like that.
Well, if you had chronic ear infections as an 18-year-old over an extended period of time, that might actually affect your speech perception abilities. So, we do see that in patients who lose their hearing, who have a moderate or moderate severe hearing loss bilaterally that's acquired in their teens or early 20s or early 30s. And after an extended period of time, that can affect both their perceptual abilities but also their production as well. So you're not looking at the same mechanism because it's not a developmental issue, but it would still have effects. Okay. So the 3 studies that I'm going to be telling you about are all based on the epilepsy model. Now, the first question you might ask is, so why are we studying auditory processing in seizure patients? And there are actually a number of reasons for doing so. One is that typically there's a higher prevalence of auditory processing difficulties in this population, on an order of about 10 to 15% as opposed to the 4 to 7% that we see in the normal population. And so this makes it easier for us to do comparative studies in this group. Most of the seizure patients that we see don't have any structural abnormalities, neurological abnormalities, don't have tumors, that type of thing. So it's similar to the patients that we see in clinic. We can do a lot of testing with these patients. We have the ones that we see in the hospital, we have a lot of information in terms of neurological workups on them. And the group of patients that I'm going to be talking about undergoes some surgical procedures that most normal populations don't undergo because they don't have seizures and for the most part aren't candidates for the surgeries that I'm going to be talking about. So we can do repeated measures testing in this group, so you don't have to compare a group of patients to another group of patients. You can use each patient as his or her own control, which is a nice way of avoiding some of the confounding effects of individual differences. So those are some of the reasons why we study seizure patients. The first study I'm going to tell you about looks at the organization of auditory functions within a hemisphere. And we're going to be focusing here on the left hemisphere. And what we wanted to do is to compare what the organization of auditory functions it looks like in patients who have behaviorally normal auditory processing abilities with those who have auditory processing disorders. And these are adult seizure patients. And the reason for studying adult seizure patients in this case is because we want to actually avoid the developmental overlay. So we want to look at what the system looks like after development. And as I mentioned before, you don't outgrow an auditory processing disorder. So it's still there in adulthood. And then the technique that I'm going to be talking about is cortical stimulation mapping, or what's also called electrical interference. Now, to select the patients, so we see a lot of seizure patients. They come in and they are candidates for surgery, and the surgery involves removing that part of the cortex that is responsible for generating their seizures. This only happens, they only become candidates for this surgery after they've tried lots of medications and combinations of medications, and they're still having difficulty controlling their seizures. And so then at that point they can become a surgical candidate. What we do with the cortical stimulation mapping in these patients is to give the neurosurgeons the parameters for the areas that they can take out. You want to avoid impinging on a motor area, for instance, or on a speech and language area, because you would have a deficit after surgery. So it helps in the planning of the surgeries. Now, in the patients that we were interested in, we wanted patients who performed well on auditory processing tasks and those who had difficulties to be able to compare what, on cortical stimulation mapping, the organization of their auditory functions look like. And so we gave all of these patients a fairly standard battery of central auditory tests that include speech and noise tests, which you can see at the top. Under speech decoding, we have a series of tests. One in particular that's been very useful is a filtered word test. These are words that have been low-pass filtered, so the high-frequency information, 1,000 hertz and higher, is missing, which is associated with consonant information. And that's been a fairly sensitive test for identifying children with decoding type difficulties. We also give tests of auditory attention and memory, sequencing, and then we look at neuromaturational issues as well. So all of our patients went through these tests to try and identify who did and did not have an auditory processing disorder. And then we picked from those patients that met these inclusion criteria. We wanted to make sure that they had normal peripheral hearing, no history of a hearing loss. They all had normal brainstem auditory functions as measured by the reflexes and the ABR, which is auditory brainstem response testing that I mentioned before. All of them had normal MRI studies. There was no comorbid neurological problems. They didn't have tumors or any other type of neurological disorder in their history. Cognitively, they were normal in that full-scale IQ scores were above the normal range, so at or greater than 85. And then we looked for patients who had a seizure focus that was not in a primary language area, so nowhere around the perisylvian region. And that was because patients who have seizures in those areas that can often end up moving language functions elsewhere, so you get atypical patterns of language organization, which is what we wanted to avoid. We looked also for patients who began having seizures only at or after the age of 10 years old. And the reason for this is children who have seizures certainly before the age of 5 years often also show atypical patterns of language organization. So this is another reason for including this as an exclusion criterion. And then all of them were left hemisphere dominant for language on the WADA test, which I'll come back to and tell you a little bit about in a minute. Okay, this is a very hard slide to read, but we found 14 patients, and this is an ongoing study, who met all the inclusion criteria and also performed within normal limits on the battery of central auditory tests. These were eight women and 6 men. They ranged in age from 16 to 55. Mean age was around 32 years. And as you can see, their full-scale IQ scores were in the normal range, and seizure focus was outside of perisylvian language areas. So that means that most of them had their seizure focus in the inferior or basal and anterior temporal lobe, which is not typically associated with most of the language functions, certainly that we were interested in looking at. And then we also were able to identify 8 patients who did very poorly on our auditory processing tests and would have qualified for the diagnosis of an auditory processing disorder. And they, in particular, had the speech decoding type of auditory processing disorder that I told you about. And these are four females and 4 males. Their age range was similar to our audiologically normal subjects. They were 17 through 55, and I think their mean age is around 34 as opposed to 32, but definitely in the same area. And so all of them underwent 2 surgeries. The first is a craniotomy to implant these electrode arrays over the cortex. And so the patient comes in, they have that initial surgery, they're bandaged, they're sent up to our unit, and then they stay with us for anywhere from 3 to 4 days to a week. And during that time, we do the mapping of speech and language functions in them. So at that point, they're connected to a computer, basically, which records seizure activity. A lot of them are tapered off of their medications during that time so that we know exactly where the seizures are coming from and for us to do the mapping. And so once the grid is in, the mapping works. I'm going to try this pointer one more time. Is that better? Good, okay. The mapping works. We generate.
So what happens if
it does.
I saw it.
It's not you. Is that what you're saying?
It's a cold day in this application.
Okay, I'll move quickly. So we generate a current, usually about 15 milliamps is the maximum that we go up to between adjacent sort of horizontally paired electrodes. And the effect of the current is basically to disrupt the processing of the underlying brain tissue. And so you have the patient performing a task, you put the current on. If you're in an area that's important for that function, you'll see a disruption in the function. And that's how we do the mapping. The effects of the current are temporary. This is only on for about 5 seconds. And so this means that you can move around and map, you're right, it does fade, a number of different areas, multiple sites, and test sites over and over again in the same patient. And we identify a deficit by comparing their performance with the current on to their performance with the current off. Are there any questions about the technique itself? So we did this mapping in the patients that we talked about, okay?
No, I'm just trying to think, remember what the tests were, so.
We'll come to that. I'll show you in just a second. So what we did during the mappings was to tack on an auditory syllable discrimination test, or discrimination paradigm. And this is a very simple binary force choice, same different type of paradigm that's been used a lot in the literature. And the patients respond by pressing a button for same or different. We don't do the testing at any sites where there's a motor deficit. We always test for motor function before we do any of the language testing. So if we see a deficit, it's not because they're having difficulty pressing the button. And the stimuli that we use, we developed with Xiaoxing Wang and his graduate students in biomedical engineering. And basically these were very simple consonant-vowel synthesized syllable pairs. And we looked at, they were contrasted by their initial consonant. We've previously done both consonant contrast and vowel contrast. For these studies, we stuck with the consonant contrast. And then as a control, we included pairs of frequency modulated tones. Now this is not an ideal control because they're not as complex acoustically as the syllables, but they were better than what we were using previously, which was just sort of pure tone pairs. And so this, if the patients have a deficit discriminating the syllables but not with the tones, then we know that it's not because they're having trouble doing the actual discrimination test itself or having difficulty with general auditory processing, that there's something else involved. And so what you see here, these are sites where we elicited with cortical stimulation deficits in patients' ability to discriminate those consonant vowel syllable pairs. These sites have been normalized to a standard brain atlas, and the reason for doing that is that we want to control for any intersubject differences in brain morphology and anatomy. It's a fairly standard thing that's done. The dark filled circles are where the deficits were located, and the light gray lines represent areas where we did the testing but did not elicit a deficit. And what we found is that in 13 of the 14 patients tested, we found deficits in their ability to discriminate those syllable pairs, and the deficits are fairly localized into what we would call, the area here, it's in the temporal lobe, and it's what we would call the superior temporal gyrus of the temporal lobe. It's kind of where they're found. I should mention that their ability to discriminate those frequency modulated tone pairs was intact. A deficit is defined here as a statistically significant difference from their baseline performance. We had enough stimuli to do this for the patients. Okay, so that's what we see in the patients that had normal auditory processing abilities on our clinical tests. We have a former graduate student from biostatistics who has taken on the task of developing a statistical method for giving us better delineating the cortical areas that are involved in the deficits that we see. And she does this by incorporating, her name's Diana Miglioretti, and she does this by incorporating information about the distribution of the current density under the electrodes, also by incorporating information about differences between patients in the actual electrode coverage, and incorporating information from the whole group, from the population, as to where the deficits are. And so what she's been able to develop, and you see an example here for our 14 patients, are probability maps. So where the highest probability of a deficit is the darker the color. And in this case, it's easy because the highest probability of the deficit is where it was elicited in each of these individual patients. And I think this technique is ultimately going to be most beneficial to us for comparing performance across different tasks. But we can actually learn some information even just by looking at this particular task. One of which is, I mentioned that 13 of the 14 patients had a deficit. Patient number 13 did not. And so the question is why? Why didn't we elicit a deficit in this patient? And as it turns out, you can see here that the electrode coverage, these very light gray areas, did not match the area which was the highest probability of getting a deficit across the group. And so it may be that we didn't get a deficit in this patient because there was insufficient coverage of that high probability area, is one possibility. And then the other piece of information that we got from these probability contours was when we look at the groups together, when we just look at the electrode sites themselves, it sort of seems like this grouping here in the superior temporal region. But actually there are two centers, a more anterior one and a more posterior one. Okay, so you may see two centers. Let me make sure this pin is not retracted. There. So we have two centers here, an anterior one and a more posterior one, and that wasn't so clear from just looking at the maps themselves, and it became more clear when she did this analysis for us. So now the question is why? I mean, why is it that some patients are clearly grouping more anteriorly and some patients more posteriorly? We know it's not gender. There's a pretty much even division of gender here. And so it may be that there are some functional differences in how they're processing the speech information that we just can't get at with our tests. And so that's something we're going to go back and look at a little bit more carefully with more patients. But in either case, even with these two centers, we're still talking about a relatively circumscribed region that's involved in supporting our ability to discriminate syllable sounds.
So all you had to do here was discriminate
that type of syllable. We
So
didn't.
do you think you would have been, I'm sort of wondering why you don't see it in what I usually think of as the speech areas. Partly you didn't cover those areas very heavily.
So by speech areas, you mean what?
Well, farther up into the parietal a little bit and towards the tongue a little bit.
So we typically get deficits in the parietal lobe when we do tasks that involve more semantic or lexical level processing, like comprehension. And so I didn't bring it, but I mean, we have a map for the same patients of comprehension, and you're absolutely right. So we get deficits in the inferior parietal region. We get it in the superior temporal gyrus, comes down usually into the middle temporal gyrus, and you then also get patients who have deficits in the frontal lobe. This task, these were syllables that were not words, and so it may be that for that reason they were able to make use of just a fairly circumscribed region.
Yeah, and if you wanted to be difficult, you could argue that this is not a speech task at all, it's an auditory task.
But then why does FM tone discrimination stay intact? When
Well, it's an easier one or something.
well, that's possible. I mean, certainly in terms of complexity, I would not be able to argue that. Let me just tell you what the patients who had the 8 patients who had the auditory processing disorders, what their maps look like. And you can see now this is very different. So these patients had deficits in at least one site. And rather than finding like we did with our normal patients where the deficits were pretty much localized to this region, we get these all over. And this is actually, sort of at the occipital parietal area, down in the middle temporal gyrus, some down even more inferior than that. And there's not only do we get deficits in these patients at more sites than we did in our audiologically normal patients, but they're really spread out. So you have that information as well.
But they're also sort of pushed away from the auditory.
Well, I mean, you have a couple here that are in here, but you're right. I mean, you might expect more. I mean, you can see the lines here where we did the testing in areas where you might have expected it, and it's not there. I agree. So what we were looking at, what I've just been talking about now, are the results that are here on the left-hand side. So these are on the top there you see the results from the patients who performed within normal limits on our auditory processing task. With the cortical stimulation, we found these very localized deficits to the superior temporal gyrus. In the 8 patients who had the auditory processing disorders, we see that they seem to recruit more cortical areas to do the same task, and the areas are distributed more widely in the cortex.
Excuse me, in this second case, these people don't perform well to start with, right?
On this task at baseline, they both performed within normal limits.
Oh, I see. So they have other disorders,
Right.
but not this one.
Right, and I'll get to that. That's going to be over here. In terms of their behavior on the discrimination task, there is no difference between the two. So they both perform, they have no difficulty with this task without cortical stimulation. Okay? So the differences that you see there are a bit at odds with the behavioral results, except if you rationalize that by saying, well, they're able to perform normally, but maybe they just need to use more or recruit more cortical areas to be able to do so. So where the two groups differ is on their performance on tasks like filtered word tasks. And so this was one of the tasks that we gave them as part of the behavioral testing that they did. And the task that we gave them was actually a word recognition task. So they had to repeat, this is for the clinical testing, they had to repeat words that were filtered. And the patients with the auditory processing disorders did very poorly on that task. The patients who I'm calling normals did not. They performed fine on it. And so now the question is, what are we going to see if we give them filtered word types of tasks while we're doing the cortical stimulation mapping? So we didn't want to give them a word repetition type of task because if we saw other areas involved, which you might expect, it may have been due to the output. So we modified the task and used CVC, consonant vowel, consonant word pairs that were low pass filtered, 1,000 hertz cutoff. And it was exactly the same discrimination paradigm. And behaviorally, our normals were at 90% or better. Behaviorally, without cortical stimulation, our second group, who we already knew had problems with this, did very poorly on that task. The best performance being around 70%, the lowest being around 40%. We weren't interested in comparing them directly. We already knew that they had trouble in this area from our clinical testing. What we were interested in is what's going to happen in terms of the cortical mapping when we ask them to discriminate word pairs that are now filtered. And so what we find for the normal subjects, I'm going to try this one again, is that here they were with the non-filtered speech. Here are our normal subjects' locations of deficits with the filtered speech pairs. And so what you can see, this actually goes back a little bit to your question, is we now get more involvement of the parietal area. The same regions are involved. Each of them also had at least one other site that was involved for discriminating the filtered speech. And so now we do see that inferior parietal involvement, and maybe they're relying on some lexical or semantic information to help them do this task. That's not clear at this point. But you do see a difference between, in terms of the distribution of the deficits for the filtered speech versus the non-filtered speech. These are the same patients. In our patients with auditory processing disorders, very different story. So they start out, they're already more distributed in terms of their deficits for the non-filtered speech, and we only get one additional site that's involved when they try to do the filtered speech. And keep in mind, they're impaired on this task behaviorally, even without the cortical stimulation. So what can we sort of say from that? Well, one thing is that we do seem to have the ability as individuals who process auditory information normally to recruit some additional left hemisphere resources when the listening conditions are degraded, in this case degraded by filtering. And that's not a capability that we see in our patients with auditory processing disorders. And so clearly there are some differences or some abnormalities in how those auditory functions are organized in the left hemisphere of individuals with auditory processing disorders as compared with those who don't have them.
So we have to simply use all the resources that are available.
Yeah, and I think that's exactly what our conclusion is with this too. I'll come back to that. So we've been talking about the left hemisphere, or just one hemisphere alone. Recently there's been some speculation that auditory processing disorders are actually the result of atypical patterns of language lateralization, i.e. that maybe individuals who have auditory processing disorders have auditory functions in the right hemisphere instead of the left hemisphere. And so the assumption underlying that hypothesis is that as normal listeners, we're not using our right hemispheres. And actually there's a fair amount of growing evidence in the neuroimaging literature to suggest that these may be capabilities that are bilaterally represented. Very hard to get at that in the normal system because both hemispheres are connected by the corpus callosum, and also because the auditory system, in contrast to all of the other sensory systems, in the auditory system, each ear projects the same information to both hemispheres. And so even if you study split brain patients who have had the corpus callosum severed, it's still very difficult to tell which hemisphere is doing what when you look at this type of task. And so the next two studies I'm going to tell you about briefly get at this with two clinical procedures. One is called the WADA test. I don't know how many of you are familiar with this. This is a test that we do to establish language dominance, a side of language dominance, it's usually the left hemisphere, in the patients who are going to have the grids and then go on for surgery. And it involves injecting an anesthesia, which is sodium amylobarbital. It's injected through the carotid artery. And the effect is basically to anesthetize one hemisphere at a time. When one hemisphere is deactivated or anesthetized, you can test the capabilities of the other hemisphere. The drug lasts for about 5 or 10 minutes. So we have a very short testing period, but it wears off and then you inject the other side and you repeat the testing. And we do this quite routinely in our epilepsy patients who are surgical candidates. The testing protocol, because we have a very short time window to work with, is also small. So our statistician won't even look at the data. She says, you can triple the number of patients before I'll even take a look. We're talking about 4, 5, 6 stimuli at a time. And the battery that we had been working with included naming, oral reading, a little bit of auditory comprehension, and some other things thrown in. But basically a fairly small protocol and no measure of speech discrimination or speech perception abilities. And so what we've done recently is to add in a syllable discrimination task to try, and this is part of a larger study to look at lateralization of speech perception abilities that we're doing with Lauren Mu, who's now at Harvard, and also with Neil Barnum, who's was on loan to us from Bill Baedeker's lab here in cognitive science. And so there are 7 of the original 14 grid patients that I told you about. 7 of them went through this modified WADA protocol where we could look at their speech, lateralization of speech perception abilities. Keep in mind, as I mentioned before, all of them, and I completely lost it, all of them were left hemisphere dominant for language. So their naming abilities, comprehension, reading abilities were all in the left hemisphere. And so the question is, what about their ability to do auditory, to discriminate these syllable pairs? And it turns out that in most of the cases, they were bilateral. And what bilateral means is that it didn't matter whether we anesthetized the right hemisphere or the left hemisphere, they were still able to perform the discrimination task at 100%. 100%, we're only talking 4 pairs here, so keep that in mind. But still, that's been fairly clear. The other patients who were determined to be left hemisphere dominant could do at least 2 of the discrimination pairs, indicating that the right hemisphere was able to do at least something when the left hemisphere was anesthetized. We see
this is pop up.
Exactly. And also place, we look at place as well, ma'am. We get a different result when we look at the grid patients who we knew from clinical testing had auditory processing difficulties. We were able to test 5 of them with this modified WADA protocol. And again, they were also left hemisphere language dominant. And the result we get when we inject either the left or the right hemisphere is that they're impaired on this task. So they're impaired whether you inject the left hemisphere or the right hemisphere. And so the description is that clinically, the term is that this function appears to be mixed. You need both hemispheres to perform this function in these individuals with auditory processing disorders.
Is that a lot of Los Angeles?
Yeah, so that's a really interesting question. So we had, in our other group, we had only two that were left-handed. In this group, even just in the 5, you see 2 here. And so the question is, obviously, is there some relation between handedness and lateralization? And we have now a total of 126 subjects that we've studied. Some of them didn't have the grids, but went through the test. And statistically, there's no correlation, which I agree is surprising.
What's the starter for left hemisphere?
Oh, thank you for reminding me. So we went back and looked at, it's kind of funny that you need 2 hemispheres to do auditory processing, and language is still left hemisphere lateralized. But when we go back and look at the results, the clinical determination was that they were left hemisphere dominant. But in these 3 cases, there was also some evidence that language was mixed for naming in these patients. So there is some bilateral involvement for those functions as well. Okay, so now it looks like from this study that in the normal system, either hemisphere can do these simple discrimination type tasks in individuals who have normal auditory processing abilities, but we get differences, or we get an atypical organization or exchange between the two hemispheres in individuals who have auditory processing disorders. So not only are we seeing differences in how auditory functions are organized within the hemisphere, but we also see differences in how auditory functions are organized or interact between the two hemispheres in these two subject groups. But as I mentioned, there are a lot of limitations of doing WADA testing, one being the very short time window that we have to work with. And so we can't get a lot of stimuli. We can't look at how well they do on filtered speech or speech and noise type tests. And so we have another, and this is the last thing I'm going to tell you about, another patient population that we're looking at. And these are children who also have a seizure disorder. These are children who've been identified or diagnosed as having what's called Rasmussen syndrome. And Rasmussen syndrome is a fairly rare childhood seizure disorder that is rare because it typically only involves one hemisphere. The seizures in that hemisphere are devastating, but it doesn't seem for some reason to cross to the other hemisphere. It also, unlike some other childhood seizure disorders, typically doesn't start until the child is anywhere between 7 and 14 years of age, which doesn't sound old, but compared to a lot of childhood seizure disorders that can start either right after birth or within the first year, it is. And so we know that at least the early development before the seizures started in many of these children has been normal. So the real reason, though, for looking at these children is that currently the most effective treatment for Rasmussen is what's called a hemispherectomy. This is a very radical surgery, and you can see this from this post-operative MRI. It involves the removal of one entire hemisphere and actually also most of the underlying white matter. And this is a post-surgical MRI study of a left hemispherectomy patient. So we recently had an opportunity to look at two girls. One was a left hemispherectomy, the other was a right hemispherectomy. It was fairly unusual because their medical histories were very, very similar. They both were right-handed before they had the surgeries. They both started having seizures at the age of 8. Their MRI studies up until that time were entirely normal. They both had Rasmussen's, and only a year elapsed before they came to surgery. And what often happens with these children is that a number of years go by before they have the surgery, and so you see a pretty steady cognitive decline in them and in their language abilities. That was not the case for these two. And so before surgery, we tested them before and after the hemispherectomies. Before surgery, they both performed within normal limits on this battery of central auditory tests. And it's the same battery that I told you about before. They had their surgeries. We have our left hemispherectomy and our right hemispherectomy. The surgical protocols were virtually identical, and they were done by the same surgeon.
Did you do WADA?
No. You know, we typically don't do a lot of WADAs in kids. And the reason is because I don't think it's very well understood, they often have an adverse response to the sodium aminobarbital. And so for that reason, the neurologists have been somewhat apprehensive about doing it in children. So after their surgery, we tested them again 12 months post-surgery, and we compared their performance on the central auditory tests. And what we found was that in quiet, when the speech signal is completely intact, so we're not talking about the filtered speech condition here, both children did very well. They perform within normal limits. And this is consistent with our WADA findings as well. Both of them had speech and noise difficulties. They were much more severe in our right hemispherectomy patient, who performed more than 3 standard deviations below the mean on the speech and noise test. And this patient also developed after surgery hyperacusis, which, as I told you before, often goes with speech and noise problems. So this is an inability to tolerate loud sounds. And she also developed some auditory attention problems. We didn't see that in our left hemispherectomy patient, but what we did see in the left hemispherectomy patient was a lot of difficulty processing filtered speech. And so what we're thinking now is that they both had speech and noise difficulties, but they may have had them for different reasons. The left hemispherectomy patient may not have been able to compensate for the loss of acoustic information in the background noise. Conversely, the right hemispherectomy patient who did fine on the filtered word test may have had trouble in background noise because of attention problems. And as I mentioned before, there's that increased attention demand in the background noise. She had a lot of problems within that area. So this is just to summarize from that third study. So it looks like either of the hemispheres can process speech under ideal listening conditions. The left hemisphere was better at processing the acoustically degraded speech. That's that filtered speech condition that we talked about. And then in background noise, it looks like you need both hemispheres, because both of the patients were impaired under this listening condition. But it also seems like each hemisphere may make a different contribution to processing speech and noise. The left hemisphere contributing the phonological information, and the right hemisphere compensating for the increased attention demands. So if we want to kind of bring together all of these studies and look at what we have, it looks like, in summary, that to perform normal auditory processing under multiple listening conditions, we're able to recruit different cortical resources within the hemisphere and between the two hemispheres. And so we get something that looks like this, where at the top we have, under ideal listening conditions, when the signal is intact and there's no background noise, either of the hemispheres can process speech. When we do cortical stimulation in our left grid patients, we see that a very small area of the left hemisphere is involved in this. Now you may ask, well, what about cortical stimulation in right hemispherectomy, in right grid patients? And we have done that before. We don't typically get deficits on this task in them. And so the question is, well, why not? I mean, if the left hemisphere can do this, if you're getting the left hemisphere deficits here, why not in the right? Or you could ask, if the right hemisphere can do this auditory processing, why are we getting the deficits with cortical stimulation in these patients? And I think that the answer lies at this level, which is that it was clear that under the filtered speech condition, the left hemisphere was better. And it may be that in the normal system, we make preferential use of these left hemisphere pathways, even though the right hemisphere can still do it. And it doesn't get at the question of why. And we can think of a couple of possible explanations. One is that the left hemisphere may be just intrinsically better at doing this than the right hemisphere. It's possible. The other possibility is that, don't forget, we know that these patients were all left hemisphere dominant for language. So all of their other language functions are in the left hemisphere, and maybe that's helping to mediate auditory processing. Certainly another possibility. That's something we need to look into. In background noise, you need both hemispheres, and they appear to be making a different contribution. Auditory attention is associated with the right frontal lobe. That may be necessary, and we know we have our region in the back here. Going from one to the other reflects the fact that we can make use or recruit different regions within the hemisphere as needed for the listening conditions. Very different pattern for our individuals with auditory processing disorders. And Bill, this goes back to what you were suggesting before. They're already, just under the best listening conditions, they're already using a lot more in terms of cortical resources than the normal processing patients are. And so it may be that under adverse listening conditions where behaviorally they're impaired, it may be that they're just maxed out. They have no other cortical resources to make use of. So that's kind of where we are now. Obviously, we need to continue these studies. We clearly need a lot more subjects before we can draw any definitive conclusions. And then I just want to mention two sort of future directions for this line of research. One is that we need to develop some non-invasive methods. I mean, in clinic, most of the patients that we see are not candidates for any of these methods. And so I think it's going to be very important to develop some non-invasive methods. And one line that we're looking at has to do with late auditory evoked potentials that can be recorded from the cortex. And one in particular that we've been interested in is called mismatch negativity, or what's also known as MMN. And this is a late potential that occurs around 250 milliseconds. It's pre-attentive. It doesn't require attention, which is useful for some of the patients that we see who have difficulty in this area. It doesn't require a response, unlike the P300, so it's good for patients who are non-compliant. We've actually been able to use it quite successfully with our children who come through the autism clinic. And you can see here, and I think part of that, the reason is that because it doesn't require response or attention, these children can be distracted by watching a video, even with a little bit of background noise is okay. That often children with autism are very visually oriented, so if you can distract them, they can actually sit still for an extended period of time while we do the testing. Then the other reason is that the response is maximal with the vertex, so you actually don't need a whole lot of electrodes on these children to get a good response. And then the third reason is we're starting now with Nathan Crone in neurology to see if we can correlate doing intracranial recordings with the results of the cortical stimulation mapping. And so this shows you on the top one of the patients who had normal auditory processing abilities. The circles in red represent the sites where, with cortical stimulation, we elicited a deficit. It's also the site where, with intracranial recordings to speech sounds, we elicited the maximal response. And then you can see in our patient with auditory processing disorders, we have deficits in more than one spot and maximal responses that are distributed as well. And so I think the electrophysiology route may be a very helpful one. There are a couple of limitations. One is that you get deformation of the signal because of the skull. So it's very hard to localize quite precisely, which is what we need to do. So a technique like MEG, magnetoencephalography, may actually be useful for us, and that's something we're starting to look into with David Popple and his colleagues at the University of Maryland. And fMRI is also a possibility as well, although I have to tell you, we are doing some fMRI studies, but I'm still, for doing auditory studies, I still think we have some technical details to work out with that. And then the second direction, just to mention quickly, is that I think we're at the point now where we can start to develop some more formalized, perhaps computationally based models of the types of cortical interactions that we're seeing. And so, this is, I think, could be a very interesting project for a graduate student to work on if they were so inclined. And it's certainly not an area that we have a lot of expertise in. But it would be very useful for hypothesis testing and for the clinical studies that we're doing. I have great collaborators in and out of the institution. Thanks. Any questions? Yeah.
You said that you were focusing on the surface of the cortex rather than the temporal plane of those studies.
Right.
Just because that's inaccessible to grid planes.
Yeah, so the grids go on the lateral cortical surface. They don't actually go in. Now, one way we can get at the information inside, so we're not too concerned about involving primary auditory cortex because we know that the distribution of the current stays within gray matter. But it would be interesting to also have information from primary auditory cortex. And we can do that in patients who have depth electrodes put into that area. Very rare that to have a patient who has both depths and grids.
The other question I had about the placement was that most of the locations that you had were actually a little bit away from the fissure. And is that because the grids themselves don't reliably make contact with where the terminal?
You mean, are they not tucking down into
right.
So when the surgeon puts them on, typically there's an effort made to tack it down at different points to the dura, and that's to keep it from moving around. But what the other advantage of that is that it can follow some of the contours, but it's certainly not perfect. And we're not going down inside the sylvian, certainly not far into that sylvian fissure for recording purposes.
It's clearly different from auditory neuropathy.
So auditory neuropathy, we think about. It's central, but it's also peripheral too, right? So peripheral in the sense of nerve. So with auditory neuropathies, you get patients who have, when you do otoacoustic emissions, for instance, with them, they're normal, but the auditory brainstem responses are not. In these patients, the auditory brainstem responses are always normal. So I think about something that would probably be lower down. Now, is it going to have an effect on cortical processing? Most certainly. But we tried to screen for that by doing the ABRs.
Other than the ABR, if you just look at one of these patients, clinically, Could you tell the difference between a neuropathy patient?
Yeah, that would be hard to do because we know that they do fine on, pure tone hearing type things, and that the problem is primarily with the speech recognition end of it. So the only way we really know is based on the results of the brainstem testing.
So that suggests that the problem could be peripheral, even though they have normal ABRs for some reason.
Well, I mean, so we do acoustic
The input
reflexes.
to the cortex is not good.
Well, but we do acoustic reflexes, we do ABRs, we do the middle latency responses and the late cortical potentials. And if there was something at the level of the brainstem, you would think that one of those four might have picked it up. And it's not to say that it's not possible, but I think certainly in the case of a neuropathy, we would have seen that. Is there something else going on at the level? I mean, certainly in terms of the efferent system, very possibly. We don't have right now the clinical tests to get at that. All right, good. I'm coming back to give you your pointer too.
Oh, well, thank you. So if I'm remembering right, correct me if I'm wrong, your standard test for measuring ability to do speech and noise is syllable discrimination, and that's against a background of conversational speech?
So we have two tests that we use clinically to measure speech and noise abilities. One test involves word recognition at 8 decibel signal to noise ratio. It's pretty much straightforward, and that's tested monoraurally.
Okay, so that's repeat what I say, basically.
Exactly. And the second test is called the speech and noise test, and it uses sentence level information presented in background noise that varies from +15 to 0 dB signal noise ratio.
So I was wondering how those two results pattern with each other, and also with a variety of other tests that I could imagine. One is word spotting. So you're listening to a cocktail party and you want to know if anybody says, says terrorist or something that I wouldn't want to be scanning for in a cocktail party in an airport. The other is all the same tests, but with musical sequences rather than phoneme sequences.
Interesting. We haven't done
so
that.
long and short sequences.
Well, that's a duration pattern. So we do have a clinical test that looks at that. Not music, but at simply differentiating short versus long pieces of auditory information, usually tones. And that's a standard clinical test that we do.
Right, you mentioned that.
Yeah. Music, I think that would be very interesting to look at, especially in our hemispectomy patients.
The background is presumably important, right? So when you talk about a background noise with an 8 dB signal to noise ratio, the background noise is white noise, it's conversation?
So we picked tests that had, that used multi-speaker babble as the background noise. And the reason being that we wanted to simulate as much as possible a normal listening environment that the children would be in, and that's what you find in classrooms. So that's why we opted not to use white noise as the background.
Right. It would be interesting to know, of course, how different kinds of noise affect people's ability.
Absolutely, and also what the threshold
music against
is.
music against speech, vice versa.
And I think you could look at that. As far as I know, there are no standard tests that look at that, but I think you could develop tests very easily to do that. Yeah.
There was
and then you
part
also asked what about the performance on the two speech and noise tests? The single word test seems to be just as good as the sentence level test for identifying speech and noise difficulties. And actually, we rely on it more because when they have more context, they can sometimes try to use that to compensate, which is understandable.
Okay, so those two pattern together across subjects,
Yes.
they correlate strongly.
Yeah, you're not going to find someone who is impaired on one and is not impaired on the other.
Okay, thank you.
Yeah.
When you're doing the cortical mapping, do you do the tones at that time?
Yeah, so we do the tone discrimination task at the same time that we do the syllable discrimination task.
And what cortical areas do you see?
For tones?
Yeah.
We don't,
Oh.
interestingly. To date, we've tested over 63 patients, and we have yet, with left hemisphere grids or right hemisphere grids, and although there are many fewer of them, to elicit a deficit in their ability to discriminate tones. And I mean, that you're not surprised.
No, I mean, cats can do that with an empirical so the whole
Okay.
thing will top it up.
Okay.
When you're comparing the left versus the right, I think one of your confusion slides, particularly fact that most of these people have language function on the left, and because of that, when you cause some function on the left, we see more of an effect than when you do on the right side of these great patients.
Right.
But the test was not, clearly the tones, they don't have a problem. That seems to indicate that the higher language functions,
Right.
which are on the left, might somehow be helping when there's a disruption.
Very
on the right
possibly to
side. But
mediate.
your tests weren't really, like, you're doing Papa and where is the,
On the filtered word test.
oh, these are filtered words.
Right.
Were they in a sentence or were they in
So the left hemispherectomy, no, there's just single. But the left hemispherectomy patient did a lot, so without a left hemisphere, you do a lot worse on the filtered word test without access to that other language information possibly than the right hemispherectomy.
Hemispherectomy patient. You had a graphic, maybe you can go back to it, maybe 3 slides. One more. Yeah, the second one with the signal
Right.
degradation.
Right.
So what test was that?
So this is the filtered speech test.
Okay, so this is filtered speech.
Mhm.
So are they listening to a single word or
Yes.
they are listening to a
Yes.
single word? And yet the semantics with associated with it, that's okay. I was trying to see what kind of high level language function would be used to compensate for
Right.
signal losses. But these are not
These are
even-
words,
These are
so,
still CVC words.
Right.
But, okay. So different.
but I mean, even if we used non-words, someone could still argue that they're still trying to access some kind of lexical semantic information too, right? And then the other possibility is that that's not what's going on, it's just that the left hemisphere is somehow better at doing this than the right hemisphere, which is what we
But
tend to
then
rely
that leads to the
on.
question, why is it better? Which might then come back to because it's something.
Yeah.
So, if I get it correctly, in the impaired patients, the area which is used to discriminate, say, ba and ba, is much more diffuse.
Did you say ba and ba?
Ba and ba.
Pa. Ba and pa.
Okay, anyway, I get this. Okay. So, it's more diffuse, right?
In our,
In the affected patient.
correct.
So what do we conclude from them?
More is
in
not
other words,
better.
we conclude how will we be able to use this to affect some cure, or are we going to just know that it is cortical and then know that it isn't, I don't know.
Well, I think the first thing to do is to identify that pattern, and as I said, that more is not necessarily better, which is a little bit counterintuitive. But the second question, that even before we get to intervention, is at what stage is this happening? At what neurodevelopmental stage is this going on, and why? And is there a thresholding effect? I mean, that's all information that we don't have at this point.
But do I understand correctly that what we now conclude is that they need aid from more areas in order to be able to perform? Not that there is something somewhere wrong, but we find that there is something wrong, and in order to compensate for it, we've got to call on more resources.
Well,
Is correct?
Yes and no. So it's not simply a matter of them needing more. Another question where you could kind of look at it differently and say, why are they using so much to begin with?
Yes.
When a person with normal auditory processing abilities can use this fairly circumscribed region of cortex. So I think that's the first question. And then the second question may be, okay, are there other cortical areas that can be recruited? If there are, why aren't they recruiting them? And we don't see any other areas recruited in these patients that are not also being recruited in our patients with normal auditory processing abilities. So I think actually the first question is, why are they using so much more to begin with?
It'd be interesting to try to find stimuli that don't require them to use that much. I mean, are there already stimuli for which they use the normal amount of cortex?
Right. Yeah, see, that's hard because, for example, if you want to say, well, what about like tone stimuli? We don't get deficits.
No, of course. I mean, it's hard to see how you would simplify it further. It's still going to be like
Right, right. Yeah, I have to think about that.
maybe vowels instead of entire syllables.
Now, I have to tell you that when we do mapping with vowel contrast, just like with the tone contrast, we don't typically get deficits. It's more just for the consonant discrimination. And you're going to say because valve?
No, no, I mean,
It may be
think
some
it's been
subcortical.
proven in all kinds of speech type of things, that vowels are more like just auditory stimulus.
Yeah, and that may be done subcortically in these patients. Absolutely. Okay, thank you.
Thank you.